I'm most honored to have Ron Hrebinko give our Paul Schellhammer Lecture in Urologic Oncology. I've known Ron since 1992-93 when we were fellows at Roswell Park Cancer Institute. Ron went to Dartmouth College, and other than that, he was born and raised and works in Pittsburgh, Pennsylvania. Ron is an associate professor of urology at the University of Pittsburgh. His accolades are many, but he is most proud of winning the Residency Teaching Award 6 times. Not many people know this, but Ron has actually had a profound effect on education of the urologists in America. After we took the boards and passed them in 1995, Ron was unhappy with the tension and the processes that went on for the boards, and he and Don Lamb found the oral review course in urology, a course that continues to this day. And I estimate over 1,500 urologists have taken the oral board review course, which used to be in Pittsburgh, Pennsylvania in the winter, but now is in Scottsdale. It's much nicer. He's one of the greatest technical surgeons I've ever seen. He is married with 3 children. His wife, Ann, is here today. It's a reflection of where we are in our lives. He also has 2 grandchildren. I'm most honored to present Ron Hrebinko as our Paul Schellhammer Urologic Oncology Lecturer.
Thanks very much, Lou, for those kind words. And as soon as I get this little cable hook back up, get started. This fell out right here. Is that it? Yeah, thanks.
No problem. Give me a second to get it up on the screen.
Just to clarify and give a shout out to Angelo Paola, who was actually the founder with Don Lamb of the mock boards course. I just took over for Angelo years later. It is my great honor to be selected by Louis to talk and give this talk that's named after a giant in our field, Dr. Schellhammer. Dr. Schellhammer was a graduate of Notre Dame. He was then graduated AOA from Cornell University School of Medicine. He did his residency after that in Cleveland at the Case Western Reserve in Cleveland. He then served in Vietnam in the Air Force, came back and completed a fellowship at Memorial Sloan Kettering Cancer Center. And then he eventually became the professor and chairman at Eastern Virginia Medical School for many years. His accolades are almost innumerable. He is a trustee of the American Board of Urology. He's a president of the SUO. He was a president of this section in the past. He is on the AUA Board of Directors, and he was the president of the AUA from 2007 to 2008. So I am very deeply honored and really not deserving of giving a lecture in his name, but here we go anyway. The title of this is In Search of the Perfect Partial Nephrectomy. I'm going to talk mostly about kidney cancer and partial nephrectomies. And the subtitle is The Ramblings of a Urologic Curmudgeon. So I'm going to get diverted away from the topic occasionally, and that's why the ramblings. And the urologic curmudgeon is me. So for those of you not familiar with the word, this kind of sums it up. Old, surly, crotchety, grumbling, reminiscing, disapproving. The original curmudgeon in my life was my very first clinical rotation in medical school. Dr. Mark Ravitch was a real giant in general surgery, and he was my very first attending. I wanted to do so well in general surgery, and I showed up and Mark Ravitch as my attending. I was just terrified. But he was a brilliant man and actually ended up being a very nice guy. He was the pioneer of pectus repair of the chest, ilioanal pull-through, diaphragmatic hernia, and the achievement I thought was most notable was that he was a stapler smuggler. Back in the Iron Curtain days, he and a man named Felician Steichen were invited on a goodwill mission trip to Russia, to the Soviet Union, and as part of their payback for the Russians for being so nice to them, they stole their surgical staplers. Back in those days, the Russians were far ahead of America in the technology for, gastrointestinal staplers, and they smuggled them out of the country and really allowed us to have them probably decades before we otherwise would have. The other, I know you're wondering, why is he talking about this guy? I'm getting to it in just a minute. He was the editor of a journal called Surgical Rounds, which I don't know if they even still have it, but it's a throwaway journal, a lot of case reports and, articles that aren't really all that important. But I would run to the mailbox. It came out every month, and I would run to the mailbox to get the copy when I knew it was coming out, because Dr. Ravitch's editorials were just so good and insightful. He, at the time of DRGs and Medicare and that sort of thing, and he would have really, really great insight as to the political motivations of people and cost containment and things that I really wish he were still alive today to hear his input. They were such well-written articles that they compiled them into a book that I think is still available online, and this is where I directly stole the term surgical curmudgeon, and these are a compilation of his editorials, a very entertaining read. So over this next hour, or hopefully less, I was going to discuss recent trends and opinions in urologic surgery, particularly kidney cancer, with which I, the curmudgeon, disagree. Now, you may ask, and rightly so, what gives me the right or authority to question these trends, or to give this named lecture in the first place? I'm not a department chairman, I'm not a world-class researcher, I'm not widely published, I'm not known outside of Pittsburgh, I'm not famous or smart or even good-looking. But I did my fellowship training with the guy who decides who gives this lecture, and that's Louis Keeler. The other thing is that we are grand trainees, or sort of grandchildren, of Dr. Schellhammer. And this is a picture of us back in our fellowship days at Roswell Park. And Dr. Schellhammer trained the man in the middle there, which is Bob Hubin. The late Bob Hubin was a really, really excellent man, one of the nicest people you'll ever meet, would have ever met in your life. Treated his patients like gold. And he was Dr. Schellhammer's trainee, and then Bob went on to train me and Lou. So we are Dr. Schellhammer's grand trainees, which gives me one more credential for this talk. I've also trained residents and fellows for over 20 years, and I have a busy GU oncology practice. I've done an awful lot of cases for somebody who is really a no-name. I've done over 4,500 GU cases, mostly kidney, mostly open, but a lot of lap and robot too. And I've done a whole lot of partial nephrectomies, over 1,000 of them. And you may ask, how does a nobody get all these referrals? And I'll tell you briefly. One is a technique or a theory that Louis taught me many years ago, the 3 A's. And I tell the residents that you need to have availability, affability, and ability in that order, and you'll be busy. Also, stay in one location. Don't jump around. It takes at least 5 years, I think, to get a good referral base up and running. So don't change jobs every 2 or 3 years, or it'll take a while to get built up. And also be nice to your patients. In Pittsburgh in particular, and I'm sure many of your communities as well, another way to get busy is to have a lot of the disease that you operate on. And these are the risk factors for kidney cancer. And in Pittsburgh, we have the top 2 in abundance. This is a map showing the age distribution among the states in America. And the dark blue, of course, is the oldest of the states. And Pennsylvania is right up there with the best of them. In fact, there are some areas of western Pennsylvania that are thought to be older than any other communities in America except for Dade County, Florida. So it's a very, very old population. And this is just a tabulature form of the same thing. Florida, #1 oldest state, West Virginia, Pennsylvania, neck and neck right behind. And I would really argue that if you eliminate the eastern half of the state, western Pennsylvania would be at least #2, if not #1. And this is another map showing the United States of obesity with the fat belt right here in the center. And our community is not red. It's not the reddish orange like the fattest states, but we in Pittsburgh are right at the very, very edge of that, and I will guarantee you we're among those. So we are really at the crossroads between aging and obesity, so we get a lot of kidney cancer prevalence because of that. In Pittsburgh, we're also the only university training program in a major metropolitan area. We do have a few training programs outside, like Morgantown, for instance, in this section, that's about an hour away. But in Pittsburgh, in the immediate vicinity, which is a decent-sized city, we're the only university training program, so we get a lot of referrals because of that. We're also geographically isolated. I know I'm beating this to a pulp, but I will get over it in a minute. We're geographically isolated. I don't think we're necessarily backward, but we're not really under the same marketing pressure that some people are, particularly like in New York. If you went to offer a patient an open partial nephrectomy in New York City, they would probably go elsewhere because they've been heavily marketed and the patients know that the robotic partial is the latest thing, and they will probably gravitate toward that. But in Pittsburgh, because of our geographic isolation, we really don't have those same pressures. I don't mean to say that we're backward. We've been doing robotics really as long as anybody in laparoscopic procedures, but that's just a fact. The Whiskey Rebellion is not really on topic, but this also further proves the isolation of our community. The Whiskey Rebellion, the center of it at least, occurred about half a mile from where I grew up, is where they burned down the governor's house in the Whiskey Rebellion. This, in 1791, the newly formed government had to pay off the debt from the Revolutionary War, and one thing they did was impose an excise tax on whiskey. And the farmers in western Pennsylvania, this is a picture here of a tax collector being tarred and feathered. The farmers in western Pennsylvania didn't take too kindly to that. And what the farmers did was a lot of the excess corn and wheat that they had in western Pennsylvania, parts of West Virginia, and even Kentucky, and they would turn that grain into whiskey, which was much more easy to transport across the Appalachian Mountains to the eastern seaboard, where they could make a profit. And there was also more money to be made on whiskey rather than corn. And it was just easier to transport a small bottle of whiskey than a huge volume of grain. So they rebelled. There were about 600 rebels, and George Washington, being the brilliant man that he was and such a great leader, devised a good plan that actually worked very, very well. Instead of going in with a small force and engaging in battle, he marched in with 13,000 troops. And when the 600 rebels saw that they were facing 13,000 troops, the rebellion was quickly squashed with very, very little violence. This is the last map I'll show you, I promise, and this just shows our catchment area. Getting back to what the original point was, this is our catchment area in western Pennsylvania, in Pittsburgh, for referrals. The border between Ohio, now you say, well, Cleveland Clinic's right here and Roswell Park is right here, but the state borders act as sort of an insurance barrier, so the insurance won't allow people to go to those places a lot of times, so we even get referrals as far north as Erie, and we take in a lot of northern West Virginia and this entire area here, which if you look geographically, at least not population-wise, but geographically, it's bigger than the entire state of New Jersey. And I said it was the last map, but I'm sorry, one more. This is the AUA sections, and just to show further that we are totally isolated here in Pittsburgh. We're a 45-minute drive from Wheeling, West Virginia, a 1-hour drive from Morgantown, West Virginia, but we're not in this section. We're not in the section with our cohorts from western Pennsylvania. We're in the section with the people from Newfoundland. So I have no idea what the sense of that is. The historical timeline of renal cancer surgery has a big gap in it. You can see that early on in the late 1800s, there was a flurry of excitement and a lot of development, not only in urology, obviously, but in general surgery and other surgical fields as well. Then there's a gap of about 100 years where really not a whole lot happened. Now, I'm not belittling the contribution of Dr. Robston and other great surgeons, but it wasn't the great excitement and technological advance that we see today. So since over the last 25 years or so, there's been just an explosion of new techniques and new processes with laparoscopic partials, robotic radical nephrectomies. And this partial nephrectomy explosion isn't just for minimally invasive approaches. Over the past 30 years, there's been a real increase, as everybody is aware, of the use of partial nephrectomy. When I was a resident in the mid to late 80s, the only people really doing a lot of partials in our area were at Cleveland Clinic and a few centers out west. Dr. Novick did quite a bit, but at Pitt, for instance, we only did partial nephrectomies for imperative purposes. So if you had a small lesion, 2 centimeters, 1 centimeter, 3 centimeters, they had a radical nephrectomy, believe it or not. If we did have an imperative partial, we usually benched the kidney, took it out, benched it, took out the tumor, cleaned up the kidney, and then auto-transplanted it. So a real big undertaking for a partial nephrectomy. But with the widespread increase in cross-sectional imaging, this has led to a diagnosis of more and more smaller tumors. And of course, as I mentioned, the population is getting older and fatter, which is probably why we see such an increase in the incidence of all stages of kidney cancer. So therefore, the need for nephron-sparing approach, the nephron-sparing approach has increased quite a bit. This just shows national trends in the percentage of partials in a 5-year period between 98 and 2002, and that trend continues. But you see in 1998, there was 7.9% of all kidney cancer surgery was done as a partial nephrectomy, and that it just doubled in 5 years. And this is my own data, not that anybody cares, but just to show you that it's the same kind of a trend. In the year 2000, I did 1 partial for every 2 radical nephrectomies, and last year I did nearly 3 partials for every radical nephrectomy. This shows the same thing in graphic form. The red line is just all the radical nephrectomies, and the blue line is all the partial nephrectomies. And that has increased quite a bit while the radicals remain about the same. So I want to switch gears and get into the meat of what I wanted to discuss. And that is, as a curmudgeon, I want to discuss things that I've been hearing over the past several years that I really kind of disagree with. At most meetings you go to, whether it's the AUA or a section meeting, the SUO meetings, these topics come up time and time again. They're trying to convince us that renal mass biopsies of all small renal masses is the appropriate thing to do. We're hearing more and more about level 1 data ruling your practice, and there are some papers particularly that I want to discuss and maybe question. And the other thing is the onslaught of the robotic surgical marketing. And not that the robot has anything bad about it. It's a blast. I love using it. But I've heard time and time again that this exactly reproduces. We now exactly reproduce the open partial nephrectomy. And I think that's not really true. The robotic nephrectomy, partial nephrectomy, really involves much bigger margins, as I'll show, and an increase in the prolonged worm ischemia time, which I don't think is exactly the way we do it as an open partial either. So first, let's talk about the biopsies. The advantage of a small renal mass biopsy is that there is a low risk of seeding. Now, this is true with renal cell carcinoma only. This doesn't really apply to transitional cell carcinoma, as you know. So every study pretty much points out that the chance of seeding the tract is practically 0. So that's not a big concern when you're advising your patients. But knowing if this is a benign or indolent diagnosis can avoid surgery or ablation or any other kind of treatment, or even additional x-rays if you're going to follow that patient in some patients. And then I wrote below there, or does it? In reality, only 12.8% of excised renal masses are actually benign, and those would include angiomyolipoma and oncocytoma for all intents and purposes. Really small lesions that are like fibromas and that sort of thing are so rare that they're not really worth considering. Other lesions that you may want to know about that aren't technically cancerous would be chromophobe carcinoma and papillary type 1 tumors that are very indolent in their behavior. So even if you have an angiomyolipoma, that doesn't mean that you need to biopsy it, and that is for sure. The great majority of these can be diagnosed radiographically. Here's a typical example of a patient with a small, dark lesion in the kidney. You'll find that its fat density, if you check the Hounsfield units on it, the density is in the minus range, and on ultrasound, that's confirmed to be hyperechoic because of the fat content. In fact, a lot of times when you can't find fat on the CAT scan, but you still suspect that it might be angiomyolipoma, almost always it'll show up on an ultrasound as a hyperechoic lesion if it's an angiomyolipoma. So biopsy of this isn't really necessary. Only 10%, and you will ask, well, what if you have a fat deficient AML? Shouldn't you try to biopsy those and find them? Well, the answer, I think, is this. Less than 10% of all renal tumors are actually angiomyolipomas, and of those, only 14% are actually fat deficient. So 86% of the AMLs are diagnosed without a biopsy at all. And if you're going to biopsy all of these, you're going to find that your biopsy is useful for less than 1.4% of all renal masses. So what about oncocytoma? That's really the one that we're interested in. 3 to 7% of all renal masses are oncocytomas. That's certainly higher with small renal masses. And you get better results with core needle biopsy than a fine needle aspirate. But despite the claims of improved diagnostic accuracy, too often our results are equivocal. Now, these are 2 pictures here, one on the left and one on the right of 2 different types of tumors. Now, to my untrained pathologic eye, the one on the left looks pretty nasty to me. This looks like this has some, I don't think they're mitotic figures, but certainly some anaplasia, and the one on the right looks benign, but it's exactly the opposite. The one on the left is actually a benign oncocytoma, and the one on the right is a chromophobe carcinoma. And this can be a bit of a tricky problem to distinguish between the 2. And this is the typical results that we get at our institution. Now, keep in mind, it's the University of Pittsburgh. This isn't a community hospital with one pathologist who's only there on Fridays. We have a very good site of pathologists, and it's a modern center. But nevertheless, even at our place, this is what we're getting. Typically, when I do a biopsy, I'm waiting to see what this biopsy report comes back, and this is what I get on my desk. Positive for neoplasm, renal oncocytic neoplasm. Okay, that doesn't tell me much. See comment. Okay, let's read the comment. The specimen consists of renal oncocytic neoplasm. The differential diagnoses include oncocytoma versus chromophobe renal cell carcinoma. The cell block material, blah, blah, blah. Recommend clinical and radiologic correlation. Well, that is just great. We'll have to go back and look at the x-rays. So this isn't anything for publication, but when I was preparing this talk, my residents did this for me. They quickly looked at the last few years to see what our results were at our center for small renal mass biopsies, and these are the results. Basically, like if you flip a three-headed coin, this is what you get. Non-diagnostic was a third of them. A third of them showed this, quote, oncocytic neoplasm, and a third were malignancies. Oncocytoma, we know, can coexist with chromophobe carcinoma. So that's always been an argument against doing needle biopsies, that you can miss these areas of chromophobe carcinoma. And this was thought to previously occur about 10 to 20% of the time. But a group recently from this section, the investigators from Fox Chase, show that that number is actually a lot lower than previously thought. And this is a publication from earlier this year. 4.2% of the oncocytomas that were biopsied were actually found or that were excised, were found to contain elements of chromophobe carcinoma. All of these were low-grade chromophobe cancers. None progressed or metastasized. Chromophobe carcinoma is indolent, but not necessarily always innocent. Presents at an earlier stage, you have a better prognosis than clear cell or papillary renal cell. It metastasizes far later, but it's not necessarily benign, especially if you have high-grade or sarcomatoid features. And if it does metastasize, it's less responsive to the common systemic therapies for renal cell carcinoma. So let's talk about the disadvantages of renal mass biopsy. Certainly, AV fistula and pseudoaneurysm are rare, but they can occur. It's less with a fine needle aspirate than with a core, but of course a core is going to give you more accuracy and if you really want a diagnosis. Another is bleeding, not to be taken lightly, 9% in this one paper in the radiologic literature. In the bleeding, at least, they found that there was no difference in core needle versus fine needle aspirate. There's obviously hematoma around this right kidney. Change in the appearance of the lesion is also not to be discounted. Usually your plan, if you're going to biopsy a lesion and find that it's benign or indolent, is to follow it and watch it. And certainly, if you do a biopsy, there's certainly a chance at 6 and 12 months or longer that you can have a distinct change in the appearance of that lesion because of some minor bleeding around the tumor. So that's to be considered. But I think an even bigger consideration is the cost. These are extremely common that we find small renal masses, obviously. And if you're going to tack on a big bill for a biopsy before you operate on all these or treat them, you're going to run up an incredible bill in an era where we really have to consider cost containment. At our institution, our pathologists gave me their charges, what they get for doing the gross and microscopic exam and then the immunohistochemical stains, and that comes out to $450 for every renal mass biopsy. That gives you, we end up with an equivocal result for $450. And these two centers out west reported their costs for the interventional radiology fee, and that was a lot of money as well. In 2005, this paper came out in the Journal of Urology, and a lot of us thought that this would put an end to renal biopsies because you wouldn't really need to do any because you could figure it out with fancy techniques using your CT scans. And what this group from Egypt showed was that there was a considerable difference in the degree of enhancement between clear cell, papillary, and chromophobe carcinoma, and I put this here in a little easier to read format, that the change in the Hounsfield units between the non-contrasted kidney images and the corticomedullary phase was 108, 56 for papillary, and 22 for chromophobe with very little overlap. So we thought this was going to be so great, but a couple years later, this group from Memorial Sloan Kettering had a much bigger series, and this time they incorporated benign pathology as well. Angiomyolipoma and oncocytoma are included here, and they showed, unfortunately, very, very little difference in the CT enhancement qualities between the three cell types. The only exception maybe is papillary renal cell carcinoma that doesn't enhance quite as much. So that went by the wayside. So in my practice, I hate to badmouth this because it is becoming, common, real common that you're supposed to refer everybody for a biopsy, but I really find the usefulness is only for large renal masses. If you question that there's lymphoma, especially if there's a lot of lymphadenopathy, it'll save the patient, potentially save them an operation if you get a biopsy of lymphoma and treat them with chemotherapy ahead of time. And for XGP, maybe. I mean, you're probably going to operate on XGP anyway, but if you have a biopsy ahead of time showing it's that, you'll know full well to give that patient a preoperative bowel prep, and you'll know to clear your day because you're going to be in for a heap of trouble that day when you take that kidney out. It's also useful if you are not planning on doing a cytoreductive nephrectomy in somebody who has metastatic disease. The kidney is often a big target rather than small metastatic deposits for the medical oncologist to have a histologic diagnosis so that they can then tailor their systemic chemotherapy accordingly. For small renal masses, biopsy is useful for proving oncocytoma in high-risk patients, and again, I don't use that very often. So done with the biopsies, we're on to another sort of pet peeve of the curmudgeon, and that's evidence-based medicine. Now, save all your booing until the end, please. Don't throw tomatoes at me. I know this is the holy grail of urology now, and I'm going to be accused of setting medicine back 50 years. But the U.S. Preventative Task Force Services Task Force showed that level 1 evidence, we all know the definitions of all these, but I just wanted to reiterate the definition of level 1 evidence, and that is obtained from at least one properly designed, randomized, controlled trial. And evidence-based medicine has been our recent holy grail. It now trumps common sense in not only kidney cancer, but also bladder and prostate cancer. I'm going to go over a couple of the more popular studies over the past few years. So I'm going to digress here a little bit and go talk a little bit about bladder and then prostate cancer, and then we'll get back to kidney cancer in a minute. This is a study that received huge notoriety. As you all know, the SWOG study looking at neoadjuvant chemotherapy plus cystectomy compared with cystectomy alone for locally advanced bladder cancer. And this was out about a decade ago, published in the New England Journal of Medicine. And in this trial, MVAC and cystectomy were given to the one cohort of patients and cystectomy alone in the other. A randomized prospective level 1 study, 317 patients, and they showed improved survival in the neoadjuvant chemotherapy group, and it was almost significant in 77 versus 46 months. So do I recommend neoadjuvant chemotherapy in all my patients? No. And the actual comments from my residents because of that opinion is, you are a dinosaur. This article was in NEJM, for goodness sake. You are ignoring level 1 evidence. But I tell them that common sense prevails. Neoadjuvant chemotherapy is a bad deal for non-responders. The total response rate for MVAC, even in the best of hands, is about 2/3 of patients. So about half of the responses are complete and about half are partial. And as you know in your own practice, most patients that you refer are elderly or sick, or they have compromised cardiac function, compromised renal function, and an awful lot of those patients don't get MVAC when they go to see the medical oncologist. They get Gem-Cis or carbotaxol, and the results with Gem-Cis and carbotaxol are not the same as with MVAC. So at best, you're going to get a 50 to 70% partial response rate, and in the meantime, 30 to 50% of the patients are going to get poisoned while the TCC progresses because they're non-responders. In this study in particular, patients in the cystectomy arm did not get chemotherapy. So this was not a study of neoadjuvant versus adjuvant chemotherapy. This was neoadjuvant chemotherapy versus no chemotherapy. And I really think a better study would have been neoadjuvant chemotherapy versus the judicious selective use of adjuvant chemotherapy based on the pathologic findings. So in real life, your patient comes back with microscopic nodal metastases, T3 disease, significant angiolymphatic invasion. You're going to refer those patients after a month or so post-op. You're going to refer them for adjuvant chemotherapy. So I'm going to change now to prostate cancer. This is another study that we're all very, very familiar with. The PLCO study, randomized controlled study of PSA screening versus non-screening. 76,000 patients, just a tour de force in our time. And there was no difference in the death rate. I remember when this study first was in its infancy, and I was early on in my being an attending, and my mother actually came to me because she's a smoker, and her internist recommended that he wanted to get her to enroll in the study for the L part of this, the lung part of the study.